Welcome to the deep dive. Okay, so we're digging into some revision notes you shared, pulling out the absolute essentials. Today, it's all about Graves' disease.
Exactly. Our mission is to give you a really clear, high-yield overview for your revision. We'll cover, everything from the definition right through to complications.
Yeah, and hopefully with a few memory aids sprinkled in. We know these medical topics can be, well, complex.
For sure. So we want to make it accessible, make it stick. Whether you're deep in exam prep or just brushing up, we'll try and keep the jargon light.
Okay, let's jump right in then. What is Graves' disease fundamentally?
Right. So Graves' disease is an autoimmune disorder. Basically, your immune system gets confused and starts attacking the thyroid gland.
Attacks it how?
It causes hyperthyroidism. That just means the thyroid produces way too many thyroid hormones.
So the immune system is actually stimulating the thyroid, not destroying it initially.
Precisely. The key players are these autoantibodies. They're called thyroid-stimulating immunoglobulins, or TSI for short.
TSI, got it.
Yeah, and these TSIs, they act like the body's normal thyroid-stimulating hormone, TSH. They latch onto the TSH receptors on the thyroid.
Ah, okay, so they're like imposters, telling the thyroid to work overtime.
You've got it. And the direct result is the thyroid just pumps out excessive amounts of T4 and T3 hormones.
Leading to that hyperthyroid state.
Exactly. And it's really important to remember Graves is the most common cause of hyperthyroidism, of an overactive thyroid.
Okay, definition clear. Let's talk etiology. What actually triggers this? Why does the immune system get confused?
Well, the honest answer is the exact cause isn't fully known. It seems to be a mix, a combination of genetic factors and environmental triggers.
Right, the classic nature versus nurture interaction.
Pretty much. The underlying process, like we said, is this autoimmune response targeting the thyroid. The immune system mistakenly thinks the thyroid needs stimulating.
And you mentioned genetics.
Yes, there's definitely a genetic predisposition. If you have a family history of Graves or even other autoimmune diseases, your risk is higher.
Okay, so genes load the gun.
An environment potentially pulls the trigger. Things like significant stress, certain infections, maybe viral or bacterial, and importantly, smoking. Smoking is a big one.
We keep coming back to smoking. Let's focus on those risk factors more directly then. Who's most likely to get Graves's?
Okay, so number one, as we just touched on, is family history. Graves or other autoimmune conditions in the family, that's significant.
And demographically?
It's much more common in females. The ratio is something like 5 to 10 women for every man affected.
Wow, that's quite a difference.
Ooh.
Any idea why?
The exact reasons aren't crystal clear, but hormonal factors likely play a role. Also age. The typical onset is between 20 and 40 years old.
So often younger adults, middle age.
Exactly. And specific genes, particularly certain HLA gene variants, are linked to increased risk too. These HLA genes are involved in immune regulation.
Right, the immune system's ID system.
Sort of, yeah. And just to hammer it home against smoking, it really is a crucial risk factor. Increases the likelihood of getting Graves and ups the risk of complications, especially the eye problems.
Okay, definitely noted on the smoking. Let's get into the mechanics now. The pathophysiology. How does it work biologically?
It all centers around the production of those TSI antibodies, the thyroid-stimulating immunoglobulin.
The imposters.
The imposters, exactly. They bind to the TSH receptors on the thyroid cells.
And the thyroid just thinks it's getting a normal signal from the pituitary gland.
Precisely. It can't tell the difference. So these TSI antibodies just keep stimulating the receptors constantly. It forces the thyroid into overdrive, increasing the synthesis and the secretion of T3 and T4.
Like the accelerator pedal is stuck down.
That's a good way to put it. And this flood of excess T3 and T4 then circulates through the body.
Affecting everything.
Pretty much, yeah. Hitting various organs and systems, causing all this hyperthyroidism symptoms we'll get to.
And it's not just the antibodies, is it? The immune cells themselves get involved.
That's right. The autoimmune process also involves lymphocytes, specific immune cells, infiltrating the actual thyroid gland tissue. This adds to the inflammation and general dysfunction.
Okay. And how do the eye and skin issues fit into this? Graves is ophthalmopathy and the skin thing.
Pertibial mesoderma, yeah. It seems the autoimmune attack isn't always confined just to the thyroid. The immune system can also mistakenly target proteins in the tissues behind the eyes,
causing the bulging and irritation.
Exactly. That's Graves' ophthalmopathy. And similarly, it can target components in the skin, usually on the shins, leading to that characteristic reddish thickening, the pretibial myxoedema.
So it's a more systemic autoimmune response in some people.
It can be, yes.
Right. Now, if someone presents with hyperthyroid symptoms, how do you know it's Graves' and not something else? What's the differential diagnosis?
Good question. Very important. You need to distinguish Graves from other things that cause hyperthyroidism. Top contenders are toxic multinodular goiter.
Where you have multiple overactive lumps in the thyroid.
Correct. And toxic adenoma, which is just a single overactive nodule. The mechanism is different. It's not the diffuse autoimmune stimulation you see in Graves's.
Okay. What else?
You might also consider Hashimoto's thyroiditis. Now, Hashimoto's usually causes hypothyroidism, an underactive thyroid.
Right.
But sometimes, early on, there can be a temporary phase where the thyroid releases stored hormone as it's being damaged, causing transient hyperthyroidism. They sometimes call it hashitoxicosis.
Ah, tricky. Anything not autoimmune?
While rarely, other nodular thyroid disease or even thyroid cancer could present with some overlapping symptoms, so you need to rule those out, especially if there are specific concerning features on examination or ultrasound. That's why the full workup is key.
Makes sense.
Yeah.
Lots to consider. What about how common Graves is?
Mm.
Let's look at the UK epidemiology.
Okay. So in the UK, Graves is definitely the #1 cause of hyperthyroidism. We mentioned the female-to-male ratio about 5 or 10 to 1.
Still striking.
And
the age.
Yep. Typical onset, 20 to 40 years old, holds true here. Overall prevalence in the UK population is estimated somewhere between, say, 0.2% and 1.3%.
So not super rare, especially for the most common cause of hyperthyroidism.
Exactly. Clinicians will definitely see it. And yeah, it's particularly common in middle-aged women, often peaking between 30 and 50.
And you mentioned links to other autoimmune conditions.
Yes, there's an association. People with Graves have a slightly higher chance of having other conditions like SLE, lupus, or Sjogren's syndrome. It suggests a shared underlying tendency towards autoimmunity in some individuals.
Interesting connection.
And just to reiterate, Graves is the most common cause of thyrotoxicosis. That's the clinical state you get from having too much thyroid hormone floating around.
Okay, good context. Now, the really practical bit for recognition, the clinical features. What does someone with Graves' actually experience? What are the signs and symptoms?
Right. Symptoms can be really widespread because thyroid hormones affect metabolism everywhere. Think weight loss, often despite eating more.
Increased appetite, yeah.
Feeling hot all the time, heat intolerance, maybe remember hot Graves. Increased sweating, nervousness, anxiety, maybe a visible tremor, like shaky hands.
What about heart rate?
Oh yeah, palpitations, a racing heart tachycardia. Fatigue is common too, despite feeling wired. Muscle weakness, especially in the upper arms and thighs. Irritability, trouble sleeping.
So mood and energy levels are definitely affected.
Absolutely. Changes in bowel habits, often more frequent stools, and for women, menstrual cycles can become irregular.
It's a lot of general hyperthyroid symptoms. What points more specifically towards Graves's?
The really key ones are the eye signs, Graves' ophthalmopathy, that characteristic eye bulging called proptosis. Maybe remember eyes pop out in Graves, plus eye irritation, a gritty feeling, maybe double vision. And then there's Graves' dermopathy, that reddish, thick skin, usually on the shins, the pretibial myxoedema.
And what would a doctor look for on examination?
Well, they'd confirm the heat intolerance, look for the tremor, check for tachycardia, or an irregular heartbeat like atrial fibrillation. They might see onycholysis where the nail lifts off the nail bed.
Onycholysis, right.
A goiter, an enlarged thyroid, is very common. It's usually diffuse, meaning the whole gland is enlarged smoothly. Sometimes you can hear a bruit over it with a stethoscope.
A whooshing sound.
Yeah, from all the increased blood flow. Proximal muscle weakness is another sign. And then there's thyroidocropy, but that's rare. It's like finger clubbing and swelling.
So are there signs that are really specific to Graves, almost diagnostic on their own if present?
The combination of exophthalmos, the eye bulging, ophthalmoplegia, problems moving the eyes due to muscle weakness, that pretibial myxoedema skin change, and the thyroidocropy, those are really quite unique to Graves. If you see those, it's highly suggestive.
Okay, so symptoms plus those specific signs point strongly to Graves. How do we confirm it? What are the investigations?
Diagnosis hinges on a few key things. First up, blood tests, essential. We measure thyroid function tests, or TFTs. That's TSH, T3, and T4.
And in Graves, what do they typically show?
Typically, TSH will be very low, suppressed, because the high T3 and T4 levels are telling the pituitary to back off, and T3 and T4 themselves will be elevated.
Confirming hyperthyroidism.
Yes. And then, crucially, we test for the specific antibodies. The TSH receptor antibodies, TRAb. Testing for these TRAbs is the key blood test for diagnosing Graves' itself. A positive result is highly indicative.
TRAb positive usually equals Graves. What about imaging? Do you always need scans?
Not always for diagnosis if the clinical picture and TRAb are clear, but imaging can be helpful. A thyroid ultrasound can look at the gland size, structure, check for any nodules.
Okay.
And a thyroid scintigraphy, that's a radioactive iodine uptake scan, typically shows diffuse homogeneous uptake across the whole gland in Graves's. It confirms that widespread stimulation pattern, but again, often TRAb is enough.
And imaging for the eyes.
Yes, if ophthalmopathy is significant, CT or MRI scans of the orbits might be done to see exactly what's going on behind the eyes.
You mentioned TRAb antibodies. Are there others?
Yeah, antithyroid peroxidase antibodies, TPO antibodies are often present too, maybe in about 75% of cases, but they're less specific. You can find them in Hashimoto's too. So TRAb is really the main diagnostic antibody here.
Got it. TRAb is the key. And that diffuse uptake on the scan just confirms the whole gland is involved.
Exactly. It helps rule out things like a toxic nodule where uptake would just be in one spot, or multinodular goiter with patchy uptake.
Okay, so summarizing diagnosis, clinical picture, suppressed TSH with high T3, T4, positive TRAb. Ultrasound or scintigraphy might add detail if needed. So once it's diagnosed, how is Graves managed, particularly here in the UK?
Management generally falls into two camps: pharmacological treatment using drugs, and more definitive treatments like surgery or radioactive iodine. It's tailored to the patient.
Let's start with the drugs. What's the approach?
Okay, pharmacologically, there are two aims. First, manage the symptoms quickly. Second, reduce the thyroid hormone production.
How do you manage symptoms quickly?
Usually with beta blockers. Propranolol is a common one. It helps control the rapid heart rate, the tremors, the anxiety quite effectively while you wait for other treatments to work. If beta blockers aren't suitable, calcium channel blockers like diltiazem or verapamil might be used. The goal is to taper these off once the hyperthyroidism is under control.
Okay, so that's for symptom relief. What about tackling the hormone overproduction directly?
That's where the antithyroid drugs, or ATDs, come in. Usually started under specialist advice from an endocrinologist. The main ones are carbimazole and propylthioresal, often called PTU.
And how do they work?
They block the thyroid gland's ability to actually make thyroid hormones. It takes a while to see the full effect, though, usually around 6 to 8 weeks for hormone levels to normalize.
One preferred over the other.
Generally, for most adults who aren't pregnant, carbimazole is the first choice. PTU is often preferred in the first trimester of pregnancy, as carbimazole has a small link to certain birth defects. PTU might also be used if someone's planning pregnancy soon.
Okay, good to know the pregnancy considerations. So, medication can control it. What if that's not enough or not the long-term plan? What are the definitive options?
Two main ones: surgery, thyroidectomy, and radioactive iodine treatment, often called RAI.
Let's take surgery first. What does that involve?
Usually it means removing most or all of the thyroid gland, a total or near total thyroidectomy. This minimizes the chance of Graves coming back, but you need to get the thyroid level stable with ATDs before the operation.
And what happens after surgery if the thyroid's gone?
Then the patient can't make their own thyroid hormone, so they become hypothyroid. They'll need lifelong thyroid hormone replacement therapy, usually with levothyroxine.
Okay, and regular blood tests to check the dose.
Exactly. T4 and TSH levels need monitoring. Surgery has potential risks too, of course: infection, bleeding, damage to nearby parathyroid glands causing low calcium, or rarely voice changes from nerve damage.
Right. What about radioactive iodine, RAI? How does that work?
With RAI, the patient takes a dose of radioactive iodine, usually as a capsule or liquid. Because the overactive thyroid laps up iodine, it concentrates there. The radiation then selectively destroys the thyroid cells, reducing hormone production over time.
Does that have side effects? You mentioned the eyes.
Yes, that's the main consideration. RAI can sometimes worsen existing Graves' ophthalmopathy. So if someone has significant eye disease, RAI might be avoided, or they might be given steroids alongside it to try and prevent worsening.
And the long-term effect of RAI. Similar to surgery.
Pretty much, yes. It usually results in permanent hyperthyroidism because it destroys the thyroid tissue. So most people need lifelong levothyroxine replacement after RAI too.
So just to recap management points for the UK, ATDs like carbimazole are often first line, maybe with propranolol initially for symptoms. Referral to secondary care and endocrinologist is standard.
Correct. Carbimazole might start around 40 milligrams daily, then adjusted. ATD treatment typically lasts 12 to 18 months.
And if it comes back after ATDs, or doesn't respond well?
Then RAI or surgery are the main options. RAI is often used, but remember the contraindications: pregnancy, usually under 16s, and severe active eye disease.
So 3 main pillars: ATDs, RAI, surgery. Choice depends on the patient.
Absolutely. Patient preference, severity, age, comorbidities, eye involvement, they all factor in.
Okay, that's management covered well. What's the long-term picture? What's the prognosis for someone with Graves?
Generally, it's favorable. With the treatments we've discussed, ATDs, RAI, surgery, hyperthyroidism can be effectively controlled in most people.
Is it usually cured, though? Or does it linger?
It can have periods of remission and relapse. Some people achieve long-term remission after a course of ATDs, maybe 50% or so, but others will relapse, especially after stopping the medication.
So ongoing monitoring is key.
Definitely. Regular thyroid function tests and follow-up are essential, even if someone seems to be in remission.
And the eye disease? Does that always follow the thyroid?
Not necessarily. Graves' ophthalmopathy can sometimes run its own course. It might improve with thyroid treatment, but it can also persist or even worsen independently, needing its own specific management.
Right, treat the eye separately if needed. Okay, finally, what happens if Graves isn't treated properly? What are the complications?
Untreated or poorly controlled, Graves' can be serious. The most dramatic complication is thyrotoxicosis, or thyroid storm.
That sounds bad.
It is. It's rare, thankfully, but life-threatening. It's a sudden, extreme surge of thyroid hormones causing severe symptoms: high fever, extreme tachycardia, heart failure, confusion, delirium. Requires immediate emergency treatment.
Wow, okay.
Yeah.
What are the risks?
Well, long-term uncontrolled hyperthyroidism puts a huge strain on the heart. It can lead to arrhythmias like atrial fibrillation, which increases stroke risk, and eventually heart failure.
Affects the bones too, right?
Yes, osteoporosis. Excess thyroid hormone speeds up bone turnover, leading to weaker bones over time.
And pregnancy.
Definitely needs careful management. Uncontrolled Graves in pregnancy increases risks for both mother and baby, things like preterm birth, preeclampsia, low birth weight, and potential thyroid issues for the baby.
And the eye complications can be severe.
In severe cases, yes. If the pressure behind the eyes gets too high from swelling, it can compress the optic nerve, potentially leading to vision loss if not treated urgently.
And any link to other autoimmune conditions developing later.
Yes, there's a slightly increased risk. People with Graves might be more prone to developing type 1 diabetes or vitiligo, for instance.
Sure.
It underscores that underlying immune system tendency.
Okay, a really thorough deep dive there. So, quick recap. Graves' autoimmune hyperthyroidism via TSI antibodies. Risks: family history, female, smoking. Diagnosed with TFTs and TRAb. Managed with ATVs, RAI, or surgery. Prognosis generally good, but watch for complications like thyroid storm or eye issues.
Nicely summarized. And remember those little mnemonics: hot Graves for heat intolerance, eyes pop out in Graves for proptosis. Early recognition and treatment are key.
Absolutely. And for everyone listening and revising, hopefully going through this helps solidify things. Revisit your notes, listen again if needed.
And maybe a final thought to chew on. Given this complex mix of genetics and environment in Graves, what wider implications does that have for how we understand and maybe even prevent or manage other autoimmune diseases in the future? It's a really active area of research.
Definitely something to think about. And if you are studying, don't forget PassThemsRA.com and FreemSalA.com for more resources.
Great resources.
Thanks so much for joining us on this deep dive into Graves' disease.